Sure. Yeah, thanks. Hey, everyone. Welcome in. Wait just a little bit to get started, but thanks for joining us today. Okay, you're 1 minute past, so can get started. So thanks for joining us. So I'm Kelsey. I'm the program manager here with MapNet in Boston. So we're very excited to have Dr. Needham speak with us today about their work in California to improve outcomes for individuals with early psychosis. So as a brief introduction, Dr. Tara Needham is a licensed clinical psychologist and professor in the UC Davis Department of Psychiatry. She identifies as a white, cisgender, heterosexual woman and a consumer of mental health services, and she comes to this work from both personal and family experience. So as the executive director of the UC Davis Early Psychosis Programs, Dr. Needham supervises clinic and training activities and coordinates outreach and educational presentations within Sacramento and across California. Dr. Needham's research uses mobile health technology to enhance early intervention and treatment of youth and young adults with serious mental illness. And she also directs the EpiCal Training and Technical Assistance Center, which seeks to bring evidence-based early psychosis care to all Californians. So thank you for being here with us. And I'll hand it over to you to talk about all of that work and more.
Fantastic. Thanks so much, Kelsey, and thanks so much to MapNet for inviting me to come today. And thanks to everybody for joining this early, well, for me, early on a Friday morning. Today I'm really going to try to take you on a bit of a journey. It's been my journey, but to me, I think it really sort of illustrates the thoughts that we are having in California as a team about how we improve the lives of the individuals we serve. And in particular, those individuals have psychosis. They may be at high risk for psychosis or have had their first episode of psychosis, but we're trying to think deeply around how we do a better job in this work. So I'm going to go to my objectives here. So one of the big things I want to share with you today is the continuum of psychosis and some of the work that we've been doing in our team to rethink that in partnership with our lived experience integration team. So these are newer slides, hot off the press. And so we'll really appreciate your feedback and thoughts as I present them today. Then I'm going to pivot into talking about how social and structural factors can impact the course of psychosis and the outcomes that we see. And then many of us work in coordinated specialty care or early psychosis programs. So how do we take this information forward into our work today, next week, with the humans that we are trying to serve? Whoa, my picture just popped up on the other side, and that is
Oh, sorry, I just spotlighted you.
It was like, that is not the human I want to see right now. Okay, great. Let me hit some disclosures. I'm a founder and board member of a mobile health technology company, Safari Health. I'm not going to be talking about any of that today, but I like to be transparent. As Kelsey shared with you, my positionality statement, and so I think it's really important to be transparent about my positionality because I think it influences the work that I do and the things that I say. So those are the positions I come from. I also want to really acknowledge that the information I'm going to be providing here today reflects my perspective, my experiences, my knowledge. I will cite other people's work where appropriate. All right. So when I was a youngin' in grad school, I was very interested in cognition and the brain. And this was a time in psychosis work where we felt as a collective that this was a brain-based neurodevelopmental disorder. And if we could just find the parts of the brain that were responsible for contributing to these symptoms, we would then find solutions. And so you can see here, these are a number of different papers that I did as I was really trying to understand how cognition was related to, clinical symptoms, social and role functioning, these different aspects of outcome that we tend to talk about in psychosis. And this was interesting and fruitful work. However, I think my time has really taken, my work has taken a pivot. And for those of you who are newer in this field, you might believe you have to pick one path and stick with it. But I'm here to tell you that that's not true. Sometimes there are other really exciting opportunities that are presented to you, and it can be really wonderful to take those opportunities and to grow and to change. So I made a hard pivot. So this pivot was in some ways driven by my other hat. I work as the executive director of our early psychosis programs at UC Davis. So, and our clinics have been around since 2003. They were started by Dr. Cameron Carter. I had the pleasure of joining the team in 2008, and we expanded to serve Medicaid populations in 2011. And so since that time, I've really been working on my clinical side to bring coordinated specialty care and high quality early psychosis services to the communities of Northern California. And in doing that work, in being, each day sort of involved in supervision or direct care, you start to see the complexity of what folks are walking in with. And it makes you kind of rethink a lot of the ideas that you've had, or I like to say been inculcated with as particularly an academic clinician in the early psychosis space. And so I started to really be curious about who we were trying to serve and as well, what we were trying to offer them. So in 2019, well, actually, I started in 2014, but I sort of got involved in evaluation of early psychosis programs across the state of California. California had invested a lot of money in new initiatives around prevention and early intervention of mental health challenges. And one of those big spaces was early psychosis care. And the state was very curious about how was this investment leading to better outcomes? And I care about outcomes. And so I was like, hey, I'm very interested in helping you answer that question. So worked with my team, including Mark Saville, Rachel Lowy, and we, I'll say, attempted an evaluation of early psychosis programs across the state of California. And what we really found is there was a lot of diversity in what was happening. Most programs sort of grew organically. The state did not provide a ton of top-down structure or guidance. And so everybody was trying to figure out what was happening on their own. And so this paper really illustrates that complexity and the challenge then that arises around evaluating outcomes. It's hard to evaluate outcomes when everybody's doing something different. So we then, as a group, embarked on this larger project we call EpiCal. And it is part of the EpiNet network. So we're hanging out over here, California, over on by ourselves on the West Coast. And many of you are familiar at this point with what EpiNet is. And so within EpiNet, we created a harmonized database of outcomes and clinical measures, things we thought were important if we were to try to understand what was happening in early psychosis care in the US, how we would be able to track outcomes, different things like that. So we were one of the first groups that were part of EpiNet. And in our program, these are my wonderful partners in this program. You know, there's us at UC Davis, Rachel Lowy's team at UCSF, Todd Gilmer's team at UC San Diego, Kate Hardy's team at Stanford, and then our funding partners, which include the Staglins Organization of One Mime, our EpiNet R01, and then our partnership with the Mental Health Services Oversight and Accountability Commission. We actually have a partnership now with Department of Healthcare Services here in California. And so we started out as a learning healthcare network, as I was saying. We started out with this idea of how do we understand what's going on? But we always knew that there would need to be training and technical assistance. So what's going on? Oh dear, we need to make some improvements. How do we do training and support to do better? And that these two things should feed back and forth. And so now EpiCal is not just a learning healthcare network. We are also a training and technical assistance center. There are these two pieces that work together. So what does our platform look like? How do we provide this outcomes data collection across our state? So in that earlier paper that I sort of showed you from 2019, when we learned about all of the diversity of what was happening in California, we talked a lot to providers, service users, family members, state partners, county partners. What is it that you really want? How could we do better? And one of the really big themes I heard from clinic leadership was, and I experienced myself, was I'm very tired of collecting measures, putting them in an Excel spreadsheet, sending them to the state and having them like get lost in the ether. So that was something we really heard at the provider and the clinic level. Please don't ask me for data that has no utility to my work or to the folks I'm trying to serve. One of the other big things in my mobile health technology work that we talked about and thought about was how do we engage service users in data collection? One thing we realized is that oftentimes in state level reporting, this data was coming out of clinical service and being reported to the state, but that was never shared with the service user. They didn't really have any choice in how that data was used. They didn't even know what was happening. So how do we empower them to sort of understand what their data is being used for, allow them choices around that? We also really recognized that a lot of our service users and family members or support persons, weren't actually being asked a lot of questions. Sometimes all the data was coming from the provider level, and the providers felt very burdened. My team, working in Medicaid populations, the paperwork is high, stress is high. It is a lot to ask them to do more, fill this out, provide this data. They don't really see it as beneficial, and so there's not a lot of motivation to do it. So we had a lot of things that we were being asked to do. And as I mentioned before, at the state level, they wanted to know how these programs were helping. So lots of different levels of folks with lots of different thoughts and feelings. And so we really tried to design Beehive, which is the name of our platform, with all of these needs in mind. And so this is a tablet-based platform. And as you can see here at the individual level, we use iPads. And at that level, it collects data from service users and from family members on a variety of different measures, some of which are core measures in EpiNet, others we chose as a state, and I'll get to that in a second. And so these are collected at clinic entry and then every 6 months thereafter. If the individual, if services are provided remotely, the application, thank you COVID, now can provide a web link so people can go into a web-based application and complete the surveys there. We had to put that in because things began during COVID. So we now have a tablet application and a web-based portal for individuals and their support persons. So individuals identify primary support persons, and those individuals are also pushed surveys. Because again, we weren't asking them many questions. We weren't engaging our support persons, this individual's community, in understanding how things are going and where the needs were. So that's at the individual level. This data is all ported forward in real time to a provider level dashboard where folks across the CSC team are physicians, nurse practitioners, clinicians, case managers, peers, family partners. Everybody can go in and sort of see how things are doing for a given individual over time. And we co-designed this platform to be able to be used in session so that the provider can look at the data and discuss it as part of care. At the clinic level, that data is further summarized to allow our administrators to see what's happening in my program. Do the demographics of the population reflect the demographics of our community? Are we seeing improvements in different metrics that we would think we're supposed to be addressing? There's also a little toggle that allows you to turn on and off comparative data so that you can see how your clinic or how this individual is doing in relation to all the other service users on the system. And we have about 600 individuals on the system right now. There's a barrier between the clinic and the state. So when my team logs on at the state level, we can only see basically pseudo GUIDs, GUIDs, numbers, not names. We have very limited access to identifiable information. We can see some dates of service that are provided by the clinicians, and then we can also see zip code. That's it. All other identifiers are stripped off, but we can download the data and do summary reporting at a clinic level, county level, or even at the state level. And that really helps to support the state and the clinics or the counties in understanding how things are going on. So this is the data system that we have built. When I first started doing this work in 2019, we began this work with a couple of counties. So the counties in yellow are folks that came into our Learning Healthcare Network first. And these were counties that put their own money into the conversation. And this was because we had state dollars that were for innovation to really show how new things or important projects were impacting our state. And so Sonoma, Napa, Solano, Stanislaus, Los Angeles, Orange, and San Diego counties all came in first and said, we want to show the impact of our first episode programs as part of this. That actually enabled us to compete for EpiNet. And so we went in and thankfully were awarded the EpiNet grant, and that allowed me to bring in a couple of other counties. So Sacramento County, San Mateo, and then we were able to bring in universities. So we brought in Stanford, a number of different UC programs, UCLA, UC San Diego, my own program in Davis, in Sacramento. Sorry, I've got to let my dog out. I apologize. 1 second. Luna, get my life hard. Benefits and challenges of working from home. Okay, so this was the small group that we started with in 2019. Here's where we are. Well, this was in 2023. So in that 4-year period, we went from having a group of counties and universities who are committed to this, that either kicked in their own funding or were supported with federal funding, to then really being able to get the support of the state through the Oversight and Accountability Commission, as well as the Department of Healthcare Services. So we were able to bring in dollars from the SAMHSA Mental Health Block Grant to spread across the state. And what is so exciting about this is that we were able to bring in a number of our rural and remote counties. So up here in the north of California, everybody, if you've never been to California, everybody, when they think of California, thinks of San Francisco or Los Angeles. So you either think like a bunch of buildings or you think a bunch of buildings and a beach. And actually a ton of our state is covered in beautiful forest. And so it's very rural and remote up here. This area down here is actually Yosemite and other amazing national parks. And then in the center here is probably where you get your almonds and your strawberries. We supply a lot of agricultural products to the nation and abroad, and that is from our Central Valley. So we were really thrilled to see this expand beyond urban and suburban into more of our rural and remote communities. And so here you can see in the yellow were counties that we brought in through either TA dollars or Learning Healthcare Network dollars. And you'll see in blue were other states that came in because of grant dollars. So big expansion, very exciting, slightly overwhelming. So that's sort of, so I think it's just sort of important to lay the groundwork that in academia, we often sort of start in this very narrow space, right? And I started in cognition and outcomes. And as I had more and more experiences, I sort of started to see that there could be more things impacting outcomes. And I was very lucky to have these opportunities to explore that within broader communities across the state of California. And so here we are now with this growing statewide network. And, okay, so how are we going to understand the needs and experiences of these very diverse communities so that we can build data collection platforms that measure what matters? And then, how then also do we, think about how to provide service in that context? So these two different pieces, right? This TA and training, how do we improve the care? How do we collect data to see if we're doing that, if we're impacting the outcomes that we are and we want to? And if we are not, how do we change the training that we're providing? So these two things go back and forth. So I think one of the biggest questions, I'm gonna pause. I see a question in the chat, so I'm gonna go back. Are there unique aspects of the unaffiliated groups that prevented them from joining? Thank you, Kelsey. So, I think some of these counties that you see, for example, in gray, these are very rural counties. I mean, I know this says Stockton. San Joaquin is involved now because this was 2023. Fresno will be involved now, but some of these other counties are very small and very rural. And one of the things about our state is that the dollars, the mental health block grant dollars, our counties have to apply for them. So everything here is done county by county. So if Tulare County down here doesn't have the bandwidth to apply this year for block grant dollars, they don't get block grant dollars. So they don't have those unique dollars to help build a program. They are sort of working with what they have locally to provide the services that they need. And so honestly, I think many of these, particularly our rural and remote counties, had the capacity to respond when the opportunity was there. And so they are lucky enough to be here now. It is not a kind of top-down statewide approach. And so that's why oftentimes you really see our rural and remote counties being left out, which is a big concern to me. Yeah. Is California leveraging CCBH dollars to fund CSC programs, so community behavioral health centers? That is a big conversation that we are having, Angela. Some of our larger community-based organizations like Felton is thinking about this. It takes a lot to move into that medical space. That is a whole pivot. And so again, you have to think about that for us at a local level with a particular organization choosing to take that lift to draw down those dollars. So I think this is definitely an area we're interested in exploring. We're just not there yet. All right, good questions in the chat. So hot off the presses, here we go. So this is a big area where we have been thinking, right? Is like, and I like to jokingly say, like, what is psychosis? This was something that earlier in my career I just took as facts, right? It's just facts. This is psychosis. And I have been blessed to be challenged on those ideas and beliefs. So in our work in EpiCal, one of our big things that we did is we started a lived experience integration team that is represented by folks with lived experience with psychosis. And I want to call out I hope you all notice I'm saying psychosis. I'm not saying schizophrenia. You know, I think of psychosis as a very broad spectrum of experiences. And so those are the folks that we include on our team. And then we also have leadership here from two of our clinicians who, you know, have been particularly interested in outreach and education in local and diverse communities. And so this team of amazing humans has worked together for over a year on the information I'm going to share with you now. And I really find this to be incredibly exciting. So I hope you all too. So we are now going to talk about how psychosis exists on a spectrum. And for many of you, you're probably like, yeah, we know this. But let's dive into it a little bit. So again, some of the things that we know, and I want you all to pay attention in particular to the language we're using on these slides. We have received a ton of feedback about language from our service users, from our family members. We love lingo and jargon, and many of the folks we work with like to use, you know, these terms as a way to maintain their power, separate themselves from the service users and the family members. And we really want to address that in the work that we do. So, you know, we like to stress psychosis looks different for everyone. Some common experiences can include changes in perception, thinking, and communication. So, for example, seeing things other people can't see, hearing things, right? Feeling things, tasting things, or unusual thoughts or beliefs that aren't shared by other people, or communication that is hard to follow. Now, clinically, the terms we like to use are positive or disorganized symptoms, but this is what those experiences are like. Another sort of group of experiences are changes in emotional expression and motivation. So this could be motivation for social interaction or participation in daily activities, decreased verbal and bodily expression, or experience of pleasure. These are sometimes called negative symptoms. And then changes in cognition. So some folks can have impacts in areas like attention, memory, or understanding new information, or being able to take in information quickly. These things can also impact the way social information is understood. I do like to highlight that is the first box, the changes in perception, thinking, and communication, that has to be present to get a diagnosis of a psychosis disorder, right? The other two are important, but aren't required. So as you know, we are working in this space with other folks who have these experiences, you know, we want to be very mindful to use their preferred terms and language. Okay. So one of the things that we really like to think about is this spectrum and help folks understand this spectrum. And what we really talk about here is impact, not what the experience is. And this could be a point of contention for some folks on the call, not how strong their conviction is. We really think about impact. So do these experiences get in the way? Do they cause worry, concern, or distress for the individual? Does it impact what matters most to the person? So when we are talking with individuals with these unusual experiences, you really want to understand how this is impacting the person as a whole, okay? And this, I know as a clinician, can be really difficult because sometimes you're hearing from the family members, well, they're not doing this or they're not doing that, or there's concerns from other clinicians about what the individual is or is not doing. That's fine. Clinically, you can take those things into account, but the most important voice in the room is the individual. So on all of these slides, you're going to see me sort of talking about how impactful something is. And so this idea of this gradient here is, to the white side is less impactful, to the blue side, the dark blue side is more impactful. Okay, then, and this is balloons. We're talking about balloons. This is how our lived experience team wanted this sort of represented. And in working, we also have a diversity, equity, inclusion, and accessibility team. And so they also are very concerned about how we can translate these concepts into other languages and cultural frames. And so we felt like a balloon was something that made sense. And so they can move and they can be distressing. And so we can think about small balloons being less distressing and big balloons being more distressing. So they can move on the impact continuum and they can get bigger or smaller based upon distress. And again, both of these things should be discussed with and defined by the individual having these experiences. So for most people, the first bubble is smaller and falls in the mild or attenuated range. So here we have someone who's seeing a shadowy figure. Happens a couple times a week, lasts for a couple seconds. It's kind of weird, not scary. Doesn't really impact daily life, friends, or homework. So for those of us who are trained on the SIPs, we can see where this would probably fall, somewhere in the 3 to 4 range, right, on P4. It's something we would pay attention to, but we're not going to say this person is really struggling, right? All right. For other people, the first balloon may be large. And some of us have experienced this in our clinical or research practice, right? Here we have a big balloon on the more impactful sides. We have distress, we have impact. I think that an unknown force is watching me and planning to hurt me. Happens daily on and off, feels highly distressing, very worried about safety, and makes it hard to focus at work. Now, why I think it's really important to call this out is because one of the big messages we hear from our service users is that sometimes their first experience is vague, an unknown force watching, right? Which feels like a sort of vague, paranoid, suspicious experience, right? But what this person is saying is, I am distressed. This is impacting me. And so I think this idea is really trying to call out, don't rely on the quality of the experience. Rely on what the human is saying to you about the impact. We've had multiple folks in our service user and lived experience feedback say, I went in with a vague experience saying how much it was bothering me and was consistently told by service providers that that wasn't psychotic or, you know, had it defined in all sorts of other ways, were discounted, dismissed, kind of told not to worry. And they, you know, that was a very negative experience in that help seeking context. So they're really trying to help us amplify, listen to us, listen to the impact we are saying this is having on us and our lives. Okay. Some little balloons can be highly impactful. And this is kind of an example that we came up with, like if your experience feels awesome, right? I am the next coming of Christ and I am here to save the world. I don't feel distress. I feel lucky. I feel chosen, right? So it's not always about distress, but it can be about impact. I've stopped talking to my friends and family because I am, you know, communing with God. I'm not going to work. I've lost my job. I am working on how to fulfill this purpose, okay? So this is an example of where impact and distress can differ. They can change over time. So here's an example, you know, something we might say is in the milder or attenuated range, I keep hearing my name being called, happens all week. Maybe I'm tired, maybe I'm imagining things. No one else can hear it. But I'm having a little trouble reading and focusing. So it's less impactful. It's not really distressing, you know, but then over time it can change. And that's important to hear because now it could be a voice calling my name and telling me to hurt myself. People can hear it when I ask. So now I'm checking in with other people. It's been happening for the past several months. People are worried about me and I'm worried too. So it's now having a bigger impact. Multiple balloons can be present at the same time. And this was, I think, one of the most important concepts that folks wanted us to be able to represent is that this is a complex space and things can be at different places and those things can change as well. So here we have something that's less impactful but has distress. I hear my name being called, happening all week. Maybe I'm just tired. No one else can hear it, but I'm very worried. So you have distress, less impact. Then you have this smaller distress, less distress balloon, but it's having more impact, this shadowy figure on the walk to school. Because they know it's not real, but they change their route. So it's having more of an impact. And then the big pink balloon. I feel like my friends are plotting against me and want to hurt me, present most of the day, lost almost all of my friends, and I miss them, but I'm very certain I can't be around them if I want to stay safe. So you can kind of see how these things may all blend together, but they have different distress and impact levels. And then sometimes they can cluster. So here we have a voice telling me others are trying to poison me, occurs almost daily, very distressing, difficult to tell if it's real or trustworthy, so a little less impactful than a visual experience, a figure whose voice I hear might be the voice telling me that others trying, might not. And then this much bigger idea, this thought that others are trying to hurt me, that occurs daily, and I'm worried about being poisoned, and now I'm not eating. So being able to pull apart those different experiences and how each one is impacting the person. Here's another example, visual perceptual changes, and then different sort of auditory changes, and then visual things that can happen. And so again, really trying to understand across these different dimensions how these experiences can impact the person. As all of us know, people don't walk in saying, hi, I'm having some psychosis. I'd like some help. There's other stuff going on. We're humans. We live complex lives in a complex world. So these experiences don't exist in a vacuum. Oftentimes, folks are trying to manage multiple different things that are happening. And so psychosis might be just one of the things that they are sort of carrying with them. It might be in the background. And so for us, we're trying to understand what the primary things are. What are the things in the foreground that are really this person's struggling with? Or is psychosis the most important thing? But we can't ignore these other things that are in the background for this person too. So really, I think the most important piece here is us understanding as clinicians, but also as researchers, what service users want from us. What is it that they want their therapy or treatment goals to be? What is important to them? And then in the same space, in the research side, what is important to folks? And how do we strive to improve our understanding of these issues so that we can build better services? As many of you know, there's a lot of other factors that come into play here, including developmental norms. Most of our programs in California go down to age 12. So we tend to work in a much younger population. And so in those spaces, right, you've got folks who might be chronologically a particular age, but developmentally functioning at a different level. We have to always consider a cultural or familial context. Is there a familial belief in ghosts in the afterlife? Or is the family using a religious context to sort of explain and understand these experiences for this person? And that all needs to be taken into consideration. I'm going to talk a little bit about environmental factors and trauma. I think this is something that we've begun to sort of acknowledge in our field as a big issue. And that is certainly the story that we hear from our service users. And then substance use. With the legalization of cannabis here in California, we have really seen an incredible rise in the number of cases of individuals who are experiencing cannabis-induced psychosis. And so I think for us, it's really become an important factor that we have to both understand and have appropriate services for. So, let's talk about some examples of cultural context. So I am seeing ghosts, right? So we have this service user over here. who's like, I'm seeing ghosts. And he's like, my mom sees ghosts too. This is something that happens in our family. This experience is super cool. We go ghost hunting. This is a thing for us. 2 to 3 times a week, I might see a ghost, and I believe ghosts are real. So really less impact, less distress. And then we have this other service user who's like, this is not my understanding of the world. No one else can see them. It's happening the same amount of time, but it's having a different level of distress and impact. I'm afraid and I can't sleep. So this is just one example of how cultural context. Here's a developmental example. I like this one. I have imaginary friends. This little girl on the left here, they're amazing. I play with them when I want to. They're real and it's super fun. Versus a young woman who is saying, no one else can see them. They don't go away. I talk to them. I don't really have other friends or want other friends, and I'm really certain they're real. So again, that's that developmental context we want to keep in mind. The take-home point here, I think, is every individual's experience is unique. And the most important thing is to listen. I think for most of our service users, and even some of our support persons and family members, is feeling as if the service community, the service provider community, the research community is not listening. And so I think one of our biggest messages from this is we need to listen better. So now that we've kind of sat there and said, okay, man, psychosis is way more complicated. How do we again kind of come back to this idea of outcomes? If we've now sort of acknowledged that this space that we are working in, that we thought was so clear, so easily defined, like those three little boxes I showed you at the beginning, right, is much more complicated than what we imagined. How do we then understand these outcomes that we're seeing? How do we then understand the poor outcomes we see with delays in care, the life expectancy, premature mortality, the rates of unemployment and underemployment, and how this contributes to housing instability, homelessness, poverty, and decreased quality of life. And then, as folks struggle when they can't get the care they need, or the care they want is not available to them, we see very high costs. And so these are some of the costs that we see, in the US. So we're sort of saying there's still a lot that we need to do better. We need to do better to improve these outcomes for these folks we're serving. So what do we do? And this is sort of where I found myself, right? And this is a question I feel like I confront regularly, is like, now that we are trying to see the situation for the complexity that it presents, what do we do? And so, here I present this young person who's coming in and saying, hey, I'm having these shadowy figures and I'm worried about my safety. How do I serve this person? And I think in the olden days, I really would have come in with a vulnerability stress model. I would have come in really thinking about genetics down here, and stress here, and how we could sort of work in these two spaces to take this young person from the presence of symptoms down to fewer symptoms. Okay, so if I were thinking about this, right, I would be like, all right, so genes. So genes, and then, okay, that takes me to neurotransmitters. All right, so now we're talking about medications and some neuroimaging, and let's look for these brain-based targets. Maybe one day we'll actually get to, really good TMS or TDCS. Okay, these are some options if we take this very medical model. But what about school? What about family? What about friends? Okay, so let's think about some supported education, and how we can get an IEP for this person. And let's do some family communication skills, and then we'll do some social skills, and we'll make sure that we address all of these things. Oh, but what about the human himself? Okay, let's make sure we are teaching some self-care skills, maybe some meditation skills, some deep breathing and coping skills. And then maybe we can bring in some technology. I know, let's use an app to track this young person's symptoms and behaviors. And maybe we can come up with a better point of intervention. As I say all of those things in a slightly hypomanic way, it feels very overwhelming. And I think one of the key things I've sort of seen as I've been working in this space is this is the level of energy with which we often approach many of our service users, right? Is a medical model. That medical model takes us in particular things. We have evidence-based practices. Let's put them all into play. All right. But is that really what we should be doing? Unsurprisingly, I'm going to say, let's take a step back. So let's take a step back. For any of the social workers or the public health folks on the call, this is probably going to speak to you deeply. You know, we tend to focus on this individual in the center of the circle. And when I look back at my early career, I think about how I was so narrowly focused on this human, but not just this human, but this human's head. And in that head, the brain, and how those experiences, cognitions, emotions, that biological, thing was the source of what was going on. And in our treatment side, you know, we tend to focus on that microsystem. We focus on, okay, what's happening in work, what's happening in school, what's happening with friends, family, that tight circle right around that person. And I think that misses a lot of the things that are also going on. So really, you know, Bronfenbrenner challenges us to step back and see this human in context. What is beyond this person and their immediate circle? And what we see is very important factors that we have not been considering or addressing. So extended family, government, religion, politics, culture, media, social factors, economic factors. So many other things are impacting the individuals we are trying to understand and therefore serve. So I think this frame, really stepping back, has been a big part of this pivot that we have tried to do in EpiCal. And it has led us to work harder to engage those folks that we're trying to serve. Because one of the biggest things we realized was that the outcomes that mattered were not being defined by the humans that we were trying to serve or understand. For example, when we go back to that state contract that I talked about in the beginning, the state wanted to know whether the money they were spending was getting the outcomes they wanted. They were very interested as well in the outcomes that other people wanted, but they really wanted to know if they could justify this expenditure in an ongoing way to the legislature. Okay, that is a very different perspective than the service user's perspective, than the family member's perspective, than the provider's perspective. And so if we're going to go and we're going to collect a bunch of outcomes, we really need to think about who defines what matters. So this is Mark Saville. He is a wonderful faculty member on my team. And we, at the beginning of EpiCal, did a huge amount of qualitative work to understand what mattered to folks in our state. So we went out, we did focus groups, almost 30 focus groups. I think we captured close to 200 people. We did them in English and in Spanish. And you can see we engaged a number of different perspectives. We have clinicians, coordinators and administrators within EP clinics, prescribers and psychiatrists, clinical supervisors, leadership and county administration. We also had other CSC team members, right? So our CSC teams have peers and case managers and support education employment specialists and family partners. Great, let's get their perspectives. Then we had service users. And then we had family and support persons. And we really wanted to see what mattered. And you can see here with the red bars, you know, the things that seem to matter to everybody. So symptoms, functioning, quality of life, very important things to all people, right? But then there were some things that differed. What we saw was that, for example, nobody really thought about mortality. That wasn't something that was coming up at all. Incarceration wasn't something folks were really thinking about either. Sometimes came up for clients. Sometimes it's very faint here, but also sometimes came up with family. Homelessness wasn't something we had team members, clinical team members say to us, this doesn't really happen for our folks. But yet clients and family members were saying, this is one of our biggest fears. We're terrified this is going to happen. Suicide was also another area that was really important to the county and to other leadership. They were seeing increasing rates of death by suicide, and they really wanted to address that. So, you know, in our battery, we really tried to capture as many of these things as we possibly could. And so Mark took this work and he put it into a figure that really helped to understand, like, as folks in these focus groups were talking about these outcomes, because what we asked them, like, what outcomes matter to you? Rate them, right? And that's that heat map that we showed you before. And we had a discussion, then we asked them to rate them again. We showed them the different tools from Fenix Toolkit or EpiNet that could be considered. We let them pick what they wanted to use. But then they brought up other things that mattered as well. And so Mark has put together this beautiful model, right, where it really is about thinking about what are the predictors, what are the outcomes, and he also has in here predictors and outcomes and moderators. So our battery really tries to understand this complex interaction between the experiences these folks are having and the outcomes that they are saying matter to them. So we have in our data, and I'll show you a little bit, we think about these as primary treatment outcomes, but some of the really important pieces that we have seen, and again, I'll show you data in a second, are things like finances. And these were things that service users and clinicians and family members brought up. That really is related to basic needs. We also had big, important discussions on culture and language and differing perspectives depending on, you know, is this a first generation family or it's a second generation, or, you know, how is their culture, their immigration status, these different things impacting their perspectives and their engagement and their access to care. Housing status. As many of you know, here in California, we have an epidemic around housing. It's really challenging for us, and it's a multifaceted issue, but this is something we wanted to think about as well. And then trauma and adverse childhood experiences. So let's dig into this a little bit more. So here's some of those modifying factors. So this is some of the data that we have, and this was some preliminary data that we've presented at conferences, but we're seeing very consistent patterns of high childhood adverse experiences in our sample. And so this is a sample of 260 individuals, and you can see this distribution. When you get above a 4, our data shows that it's associated with higher clinical symptoms, a reduced sense of well-being, higher reported suicidal ideation and homicidal ideation, and higher rates of lifetime housing instability. So these are folks who've been struggling, you know, with a lot of other things, and it impacts them in many ways. The other thing I think is really unfortunate about this data is if you have a score of 6 or higher, that's associated with a 10 to 20 year reduction in life expectancy. And so when we see higher mortality in our folks with early psychosis, is that about psychosis? Or is that about all of the other things that these folks are managing? Finances and basic needs, this is baseline data. So folks coming in at baseline, do they endorse or does their collateral or primary support person say, yeah, this person has experienced poverty? And we can see here that, about a fifth of folks have experienced poverty. And there's some folks who, in terms of number of experiences, and these are things like having, not being able to cover an emergency, a financial emergency, not being able to afford food. These are experiences that are happening in our population. We also are able to look at family communication. So looking at, this is the score 15, how are people feeling about their ability to communicate within their family? And what we see is, overall service users didn't report worse overall family functioning than their primary support person. But when ACEs were involved in that case, then we start to see a difference. So, there are particular individuals where that family support is going to be, and that communication support is going to be really critical in terms of improving how they're doing. Here's functioning, clinical symptoms, and life satisfaction. And you'll see the folks that I've got who've been doing this work. We've got people here. This is only first episode psychosis because we also have clinical high risk. But in this sample, you can see that we've got, our younger folks are really in school. They're working, they're doing school. We've got some who are in both school and work. And as the age increases, you see that drop in the green bar. School goes down. But the concerning pictures, we're seeing a little bit of a bump in school, but we're also seeing a big increase in neither. And so there's something that's sort of happening there in this transition where we are not getting folks into work. And why is that? And why is this important? These are some questions I want to give credit to Nev Jones. We worked with her around underemployment or folks not being able to pursue the things that they want to pursue. And so this is, socially and both in terms of school and work. Here we can see socially. This is the relationship between overall life satisfaction and agreeing or disagreeing with the statement of, I feel like I'm part of a group of people who share my attitudes and beliefs. I have, my tribe. And you can see that for folks who feel that way, their overall life satisfaction is much higher. My current role will help me reach my long-term goals in the career I want. If folks feel like that's the direction they're moving, they have a higher life satisfaction. This one, I feel more negative about myself or my abilities because I have experienced mental health challenges. The more they agree with that, the lower their overall life satisfaction. And this overall life satisfaction is related to the frequency of symptoms on the MCSI. So lower satisfaction, higher symptoms. So you can see how these things are all relating together in this realm of outcomes. So what do we do? What do we do? I feel like in doing this work over the past few years, it's really like taken that, snow globe and shook it all up, and all of the ideas are raining down. And it can feel overwhelming sometimes. So I think one of the biggest challenges for our field, both clinically and research-wise, is how do we begin to consider this whole person within their environmental context? How do we incorporate the role of social determinants and trauma? And then how do we, as advocates, in our communities, address systemic issues that contribute to marginalization? Because these things are not necessarily about psychosis. So this is some work, really, again, we have a DEIA team led by Dr. Bolden Thompson and Dr. Murrow. And thinking about, here's that ecological systems model, sort of adapted for Black youth. And one of the key pieces we're really trying to acknowledge and work on is that 35% of our sample identifies as a racial minority. So we have to consider these other areas and impacts that our folks are thinking about and are experiencing on a day-to-day life, like racial discrimination, the impact of religion, or safety in the community. There's so many different pieces that we're talking about and thinking about. but we need, yes, Monica, I agree, not addressing these issues are damaging to marginalized individuals. And so how do we do better there, Monica? How do we improve in that space? I really love amplifying this paper, wonderful work by Deidre Anglin and a large group of folks, including Sabrina Ereshevsky and our team, thinking about systemic racism. Like these, again, these systematized structures that maintain the power for some and marginalization for others. How do we think about these folks in a larger context and how these things impact them, right? And so how we talk about structural racism, how that impacts the exposures folks have day to day, and then how that then leads to stress, right? If we go back to that vulnerability stress model, right? I think we oversimplify that stress. We really need to think about cumulative stress, how that then impacts that human, right? Their everyday neurobiology, how they were in the womb, how that contributes to their genetics. I think epigenetics is such an important space here. And then how then we see what is psychosis in a clinical presentation. Yes, Monica, incorporating racial discrimination is very important to recovery. I think that is just a really key place that we, again, need to work. So, you know, my challenge that I put out to you all, and I certainly am taking on myself, is how do we do better in coordinated specialty care? I think one of the most important things we can do is engage the service user and their support system. You know, I will own I am a child clinician, so I am used to working with support systems. There's a lot of adult trained clinicians. And maybe you chose to work with adults because you don't like working with the family members, but they're here too, right? Even in these transition age youth, or if you have a service user who's in their 30s, they may have a partner or a spouse or kids, and you have to bring those people in. We have to support all of them. How do we support that whole system towards wellness? How do we treat comorbid conditions, not just psychosis? You know, that could be substance use, trauma, racial discrimination, all of these other things that this whole human is walking into our office with. How do we do that? And then how do we stay centered on their goals? You know, I think we often default towards symptoms. Are we managing your voices? Are we managing your paranoia? And oftentimes that is second or third, if it's even on their list of goals. Are we allowing our goals or the goals of our program or our state to define the goals for this person? Because I think when we think about program dropout, disengagement, what is the service that we're offering? Are we meeting the needs of the people who are walking in? Community outreach and education. Boy, I've been doing this a long time. This has been a huge growth area for me and our team. You know, I think especially being in the high risk space before I moved to the early psychosis space, I think there was a lot of, oh, it's my job to go out into the community and tell them about psychosis and tell them about my program and tell them to send people to me. And I think that works in some communities with some humans. But there's a lot of communities and a lot of humans that we are not reaching. And I see that so often in the discrepancy between estimated incidents in our counties and the people that are actually being served. There's a lot of differences in the population and then the clinical population. And I think as I've worked to partner with these diverse communities and counties, my approach has really been to understand what is it they need? How do they understand psychosis, right? How can we collaborate? Because I think one of the pieces we know, but we kind of don't want to give up, is that in our ivory towers, there's a lot of power, right? We maintain a lot of power, privilege, prestige by being the tellers. And it is really hard to come down out of that tower and sit in community and listen instead of tell. And I think this process of listening has also really helped me to understand how we need to grow and how we need to change to meet the needs of a much broader group of people that we have excluded for a variety of reasons. Age, IQ, substance use, diagnosis, right? We've kind of come at this oftentimes from a very academic stance, and we've excluded people. And I think we are at a point where we need to include people more. To me, I'm truly going to give a ton of credit to my lived experience team, as well as my diversity, equity, inclusion, and accessibility team. They have been transformational in helping us really rethink the work that we're doing, again, on the research side and on the TA side. And so I want to encourage all of you to include folks with lived experience in decision-making and care delivery, and not include them in a tokenistic way. Not ask for their sign-off, but ask them, what should we be doing? What should we be doing differently? What could we be doing better? And then close your mouth, open your ears, and listen. Because I think you've got to give up that power, that privilege, that prestige to really do better in this world. So, I'm glad it's a Friday. Sometimes when I talk through this stuff, I feel very overwhelmed because it's a lot, right? Psychosis isn't the simple thing we learned about in abnormal psychology. It's certainly not the simple thing that's laid out in the DSM. It is a complex, multifaceted experience that everybody understands differently. These people, us people, exist within a multidimensional environment. For all of us, that influences our development, the progression of our lives, and our illnesses. All of us have these experiences, right, in different ways. And our environment contributes to that. So both treatment and research have to consider these interrelated issues to support individuals towards wellness. And we are not going to understand causal mechanisms of illness by continuing to work in a myopic space. So our challenge is to really step back, look broader, be more inclusive. All right. I want to give credit to all of my partners. Doing this work takes an immense lift, and that includes all of our programs, our counties, our providers, our families, our service users, our state, NIH. It has really been a wonderful and challenging journey, and I'm so glad to have these people to walk with. So thank you all. I am very happy to take questions.
Great. Yeah, thank you. And echoing folks in the chat, this has been a really compelling and I think helpful perspective to have. So I'll read the first question on here from Serena, is how do we get the systems, i.e. the state, to see the needs of the individuals as opposed to the scripted outcomes that they use to assess our programs and individuals?
Oh, Serena. Hi, Serena. It's nice to see you here.
Hi.
I see lots of friends.
My camera's not working, sorry, but I'm here.
That's okay. That's okay. I see friends. Hi, Margaret. Folks, oh, hi, Kat. In the audience, it's so nice to have you all here today. How do we get the systems to see the needs? I think this is one of our biggest challenges, right? And I think it's particularly, find your allies.
It's trying for a decade.
Yeah, it's challenging, I think, in particular, because folks, like, I think we have to accept, and again, I want to own, I'm coming at this primarily from a researcher academic space first, and as a clinician provider second. We really see our service users as impaired. We use a ton of pejorative language about their experiences, their outcomes. We say, we like to talk about their level of insight in, like, the number of times I hear agnosia, it just, every time I want to vomit. I think we really see them as incapable of partnering. And so I think one of the there's a couple of strategies, right, that we have tried to employ. And again, I think there's a lot of different ways to do this is, so I showed you data, right? I showed you data around how we got, huge numbers of people, right? Qualitative data on close to 200 people is cuckoo for a Cocoa Puff. So it's like, how do you really get the input of your team members, your service users, your support persons, your community members, right? Who are saying these are the things that matter. And I hate to say it, but like oftentimes I find in the state when I show them data like heat maps, they're like, oh, this is truth. Yeah, that's got to be right, as opposed to a single human sitting next to me telling their story. Sometimes those stories can be incredibly powerful. And so I think having those stories is also really, really good. Having folks with lived experience and family members or support persons with lived experience in those spaces can be really helpful. But data, I hate to say it, it can be really helpful. The other thing I just want to note there too is that, and this is something that's come up a lot on our team, is the goals of service users and family members is different. They have different concerns, and different needs, right? And our service users would like to remind us that our family members have more power and more privilege than they do. So, you know, and I think our family, and I see it a lot of times in national spaces, we see family members or family focused organizations get a lot of power and precedence in defining some of these initiatives and not the service users. So we've had a lot of intentionality around flipping that dynamic in our team, in our discussions, even in our structure around how decisions get made. And those decisions service users make, like that's what we defer to. Family members can have input, but service users make decisions. So I think it just takes a little bit of exploration around how those dynamics play out in these different systems. And it could be different at the state level, the local level.
Right.
But it's even within your own space, how you all make decisions and who's in the room where it happens, right? Those different ways I think can help you, but it is a slow and painful process. And I have to say, sometimes, Serena, like I'll be in a room and I've had the privilege of being in these spaces, and I take it as an opportunity to be disruptive on behalf of my service users. Like I will, in a meeting, a state level meeting, say like, hey, I just want to acknowledge that we're using very pejorative language around our service users. Can we all be more intentional around taking a strengths-based approach? Like that is how I see my role a lot now. And so you might have to get a little bit more comfortable with pushing those narratives harder than you might usually do it.
Yeah, I really want to sort of organize a team, an advisory team of people with lived experience for our state meetings. That's what I'm leaving with. Thank you, Tara.
You bet, Serena.
And yeah, kind of a related question from Michelle, but she says, I'd love to learn more about ideas you have about training strategies for community engagement, especially, you know, considering the time and financial constraints and all of those other things that programs are dealing with.
Hi, Michelle. Thank you for your great question. This is, I'm going to own, this is an area of sort of tentative exploration for us. So community engagement, let me make sure first I'm understanding what you're sort of asking. So when I think community engagement, I'm sort of thinking about, I'm just gonna be quiet, Michelle. Tell me what you want me to, tell me what you want me to say.
Thank you so much. No, I was really struck by that, your point about the differences in the number of people who show up in our programs compared to the number of people who are affected is huge. And it is really clear who we've figured out how to reach and really clear who we have not figured out how to reach. And yet, I'm wondering if you've come up with any good idea. You said go out and listen, which makes a lot of sense, but I'm also thinking, listen where and by who and how do you fit that in with all the constraints and financial constraints that programs have in terms of staff time and all that, and how do you listen? And
Thank you.
maybe this
Okay.
is just an open question, but yeah.
No, it's a great question. And again, it's one that I feel like is a field we are all really struggling with. So I'm going to tell you an example of how I've been doing this work in our rural and remote communities. And then kind of what I am suggesting. And then I'm going to, well, I'll just admit, I'm still trying to solve this problem in Sacramento County. Like, just full stop. So what I'm doing in some of my rural and remote communities is, first, to that point about the resources. I'm a resource to my to those counties. So instead of asking them to do that lift, I say, and I'm doing this next week, I am going to Mariposa County, which is in the middle of like the edge of Yosemite National Park. It is incredibly rural. There are 2 main towns. It will take me 3 hours to get there. And so I'm going in and I basically said to them, hey, I'll come and I'll provide education and outreach. Like, let's talk about psychosis. Some of the slides I presented today. Invite your community, invite your clinicians, come on in, let's talk, right? And in working with them over time and doing some outreach mapping, we've noticed that a lot of folks with psychosis are going to the jail. Great, bring your jail folks, bring your probation folks. And this is partly about education, right, at a very high level, but also about understanding what resources they have and who is excited, right? And so I did a very similar presentation in another county, and the jail and probation folks got really excited. So we are building our program to meet that need. I am not building a typical CSC outpatient model. I am helping them build a program in their mobile crisis and jail services, because that is where the need is. Because I think sometimes we just have to demonstrate our value in these communities. Otherwise, and man, I've been told this so many times in Sacramento, we're cherry picking the easy clients. We are not built for use. And so how do we first hear the need of the community we're trying to serve and build our program to meet that need, and then expand where we see more needs, right? But if we don't establish a relationship as a collaborator in that system, we are simply a leech. We are there sucking away resources, taking easier clients and patients who will succeed in our limited programs. And that is not the majority of folks. So, for us, so I'll tell you, I'll kind of pivot, because in Sacramento, we're really struggling in the Asian American, Native Hawaiian, Asian Pacific Islander, sorry, it's AANHPI, community. We have a very big community. We are terrible at it in Sacramento. So a huge focus of my team in the DEIA space is just working on how we build something for the AANHPI community. We have a lot of Afghan and Middle Eastern refugees coming right now to California. We have a whole space on religion and spirituality. Just trying to educate us so that we can walk into those spaces with more knowledge and humility, right? So we take very much a DEIA lens in a lot of this work to connect to community and then build a program from that. Does that help, Michelle?
It's super helpful. My follow-up question that you probably don't have an answer to is like, how do you pay for that?
The state pays for that, which is so that is about
Okay.
how do we allocate our resources to serve the humans that need service, right? And so for us, that has really been about, we try to leverage as much of our time and knowledge to bring that into community instead of telling them what to do, right?
Yeah.
So we are like, putting trainings on a video so that they can play a video. They don't have to learn how to do that, right? The other thing I didn't say is we are really pushing screening hard. So we use the PHQ or the PQB and PQB 21. Rachel's working to reduce it with Mark Saville, but we are really saying you cannot go out and find these people. You have to screen within the services that you have. So then really understanding the system of care and where to place that so that you can catch people at their first presentation.
Thank you.
I'll probably have more to say in like another year, but it's a constantly evolving space, Michelle, as you know. Yeah. Oh, okay. I'm seeing. Hi, Cash. Nice to see
Oh,
you. I see
hi.
you came off
Hi,
mute.
Clara. Great to hear from you. And great to see you after several years.
Oh, nice to see you too.
Yes. Thanks for the wonderful talk. So I had a question. If you could tell us about your experience with measurement-based care in any way, it's been challenging for us in many ways, how to set up a way in which clinicians can actually benefit from the assessments that we do and for them to be receptive.
Mhm.
And that is actually what's going to drive them to provide more of, collect more of those data.
Mhm.
And that truly would be the way in which a learning health system would work. But it'll be good to hear your experiences, how you make that happen.
Oh, Cash, you're just taking me into another rabbit hole. So, I mean, I think this is something that I think, how do we make data matter? Like, we love data. You and I could look at data all day and be like in seventh heaven, but our clinicians didn't go into their jobs because they love data. They like people, right? And so I think one of the things, again, we've really tried to do is focus on things that will not detract from that, that interaction. We do not want our clinicians sitting there filling out forms. And so the service users are the ones that put in most of the data, right? And it's given to the clinicians. And so for us, what we have to do is then motivate the clinicians to look at it.
Mm.
And what we have found is there's a set of folks who like it really works for them. Like that's how their brain works and it works for them. And then there's a set of folks that it doesn't. And so I would say one of our big questions right now in our team is how do we sort of increase that motivation to look at the data that's available? And because what we're hearing, and we have a paper that is going to be coming out soon, I think it's in February, around our experience with measurement-based care, because we did a bunch of qualitative work with service users, family members, and providers. Service users love it. They're like, these are all the questions no one asks me. I feel like people are listening. This is great, right? Same thing for family members, not a lot of concerns, but providers, they either love it or they struggle. And so I think our most clear solution that we see right now is, well, I'll give you two. One is making sure you support that clinical team to create processes to streamline what's going on, right? You want to have it be as few barriers as possible. And then the second thing is bring the data into any space you can. So we're having our team scaffold the clinical teams and bringing in the data from the from Beehive into team meeting or supervision or, and that's, I think, been helpful to begin to demonstrate the utility to the clinicians. And then they start to use it more. It's like, you just have to get them over a hump.
Yeah.
And I'll say, Cash, early days on this, it is incredibly challenging. And that's where I think for me, again, cause good trouble is at a health system level or a county level. How are we incentivizing our clinicians to do this work, right? They are not paid well to serve high intensity folks. And at least in county systems, the paperwork is insane. So how are we using carrots? What carrots? Because we don't want to use sticks. They've got enough sticks. So how do we motivate them towards this? And that's still a very open question for me because there's a lot of diversity in that clinician space and a lot of challenges that our different providers are facing that we don't have control over.
Yeah, no, that's very helpful. Very, very consistent with our own experience as well.
Yeah, I think we're all sort of struggling in the same rabbit hole, and God willing, we'll find our way out. But thanks. Yeah. I wanted to, there's 2 more questions in the chat, if it's okay. So what are the barriers to getting lived experience individuals working in this field? Opening the conversation in the communities and listening. As a person of color, I see many service providers talk, but do not listen to the most affected community members. Yeah, Monica, I think, I think we listen, but and as a clinician, this is where I'm like, you're working with a family and the parents are like, I listen. And you're like, no, you really don't listen. It's the same thing. Like, we think we're listening, but we're not really listening. And so, I think we have a lot of work to do there. Lived experience individuals working in this space. So I think this question, I see the challenge of this question all the time. And to me, one of the most important pieces is, like, we have to remember that this space is a traumatizing space for our service users. They have been experienced involuntary holds at our hands. They have experienced arrest. They have been restrained. They have been medicated, against their will. This is an unsafe space. And we are saying, hey, come in, hang out, tell us what you think. And they're like, no. And so how do we make this a safer space? That is a real, and so if we're going to have folks with lived experience on our teams or in our conversations, how are we mindful of our language? Who gets to make decisions? Are they still totally disenfranchised? Why would they be here? Now that I really see this through a DEIA lens, as I have done a lot of work in the DEIA space. It's like, once you do that work, it's like you see racism everywhere. It's like everywhere. And so when you start to work in this lived experience space with that same intentionality, you see how we hurt people everywhere. Like those tiny microaggressions, the language we use in talking with each other, it really is about creating safer spaces that they want to be in, and then asking them how they want to be in those spaces and creating those opportunities. It is flipping, again, that power differential on its head. And that has worked for us. So I think until we do that work, we will see peers in our space and you will just have exceptional turnover. They will just come and go because they can't tolerate it, because you're traumatizing them regularly. Thanks, Monica. I appreciate that. What I'm saying is resonating. So that's really helpful. I have 3 minutes. Can I talk about jails? Kelsey, may I talk about jails? Okay.
Yes, please do.
Oh, jails. Okay, so we have a SAMHSA grant. We have one of those, we have a SAMHSA Trauma Network, NCTSN grant, doing trauma integrated treatment for folks with psychosis in our juvenile hall in Sacramento County. And the person who is leading that, Tori Galvez, is just like, she sort of was trained in that space. So she worked in justice spaces, juvenile justice spaces. So she already had a sense of the culture. And so she was amazing in being able to create relationships with key partners in that space. So just think of it as another culture that you are trying to integrate with. How are you meeting their needs? And oftentimes, when we first started working in that space, we were like, nobody here has psychosis. They can get dressed and feed themselves. And we were like, oh, good God. Okay. This is where we're at. Great. Let's talk about what psychosis is. And we had to start kind of providing very soft, subtle education because they had a frame that they were already holding. And in some ways, it's very similar to like going into a school, right? Who is very, at least in California, our schools have very limited funding for mental health. And so if we're going to go in and play with that or mess with that at all, they get really testy. And we have to be careful that we're not saying, stop doing this thing, do this thing. We're trying to say, hey, let's talk about all the things you're seeing. And so you have to sort of understand the constraints and issues that they are facing as well. And then be able to show them how you can be helpful. And so the most helpful thing we have been able to provide is services free of charge because we have a grant to their youth. So it expands what they can do. It expands the services they offer. We aren't diverting. And in doing that, they have seen the value. And so but that partnership is tenuous and requires cultivation constantly. Yeah. So I'm glad that was helpful, Stephanie. Yeah. So, all right, friends. Well, this was fun. Happy Friday.
Yeah, thank you so much. I'll echo everyone in the chat. This has been really, really helpful. I think a lot for us to think about. So yeah, thanks for joining us. Thanks everyone for sticking till 1 o'clock, and yeah, happy Friday.
Thanks everybody. Have a good weekend.
Bye.